So we're going to go over today's topic is going to be male hormones. A large portion of this is going to be directed to testosterone. There are obviously a lot more hormones in regards to male hormones than just testosterone itself. But we're going to talk about the importance of hormones, testosterone obviously being the big ones, some signs of low T, some common myths that are out there in regards to using testosterone or testosterone replacement, some pros and cons of testosterone. A big kind of issue that men go in silence and kind of just deal with it is erectile dysfunction, which can lead into Peyronie's as well, which I'll talk about that just a little bit, but that should be addressed because that's really, really important, because that not only can affect not only the male perspective, but also the intimacy in the connection with your partner as well. And then obviously, how are some things how to improve hormones. Okay, so again, as I already kind of mentioned, this is a lot more than just testosterone, right? Really important to be able to assess and getting blood work done for more than just, oh, I had my, I can't tell you how many times I have a patient come in and go, oh yeah, my doctor checked my testosterone, it's great, right? And they just end up running just their total testosterone, nothing else was looked at, right? So that is definitely doing a disservice to yourself for sure. So at the very least, we want to make sure we're assessing adrenal hormones, pregnenolone, DHEA, cortisol, aldosterone. In the literature, when we see there is, and you'll understand what this is in shortly, but when we see low LH-FSH and low testosterone, a lot of the times it is related to inhibition of glucocorticoids. So basically, in simplistic terms, when we see function of male hormones go down, a lot of the times it's in connection with adrenal function, okay, or adrenal issues. So with addressing adrenal function, you can improve hormone function just in itself without even giving you testosterone or precursor to testosterone or other modalities. We want to make sure we're having the thyroid assessed because these run off similar circuitry, okay? So the adrenals, the thyroid, and your testosterone, or your testes in this case, will run off the signaling from the hypothalamus to the anterior pituitary, and then they go to the organ site. But all of those will run off the hypothalamus and the anterior pituitary, your adrenals, your thyroid, and your sex. These can intermingle with each other. So again, it's important to assess these. And these are just some numbers that you'd want to be assessed. So your TSH, your total T4, your free T4, total T3, free T3, total T3 uptake, antibodies. These are all things that want to be assessed here. So you're kind of getting the picture. It's just not as simple as, oh, I checked my total T, doc, everything's good, right? And then we want to make sure absolutely you're having estrogen checked, your total estrogen. So that includes E1, estrone, E2, estradiol, which is typically the one that's connected the most because that's where we can aromatase. And again, I'll explain that in a little bit, but basically it just means your testosterone can be converted into estrogen. And not that it's always a bad thing, but as males, we just don't want estrogen going really, really high and basically wiping out our testosterone and converting it all over into estrogen. But that being said, we do want some, okay? And I'll go into that a little bit more detail. We always want to make sure we're still assessing progesterone. Obviously, testosterone, the reason why I started that is because it's so important. And we want to be looking at not only total testosterone, but free testosterone, okay? That's really the kind of gold standard is free testosterone. And then we want to look at signaling hormones. So FSH, LH, prolactin, sex hormone binding globulin is really important. Running at least a PSA, I'll debunk a little bit of myth around that, but PSA, that's related to the prostate. It was thought a long time ago that taking testosterone can increase prostate growth and lead to potential prostate cancer. That is completely debunked at this point. So that's one of the myths. And again, I've added some info on that. DHT, which we're going to talk about, that's dihydrotestosterone. So that's another, it's technically considered an androgen, but you can shuttle your testosterone to DHT. And again, that's pulling away from your overall production of testosterone and taking it away from usable form. But DHT is important, but there are some things. We don't want DHT to go through the roof because it can lead to male pattern baldness, but also it is important for still maintaining muscle mass, for proper cell healing, tissue growth. So we don't want this in the tank, but it should be assessed if you're doing HRT, hormone replacement therapy. We always want to make sure we run a CBC. This is the big one here, okay? Lipid panel. The reason why we want to assess lipid function, because with hormone replacement therapy, that is probably the largest side effect, surprisingly, is affecting cardiovascular function. So it's not going to cause, most likely it would not cause a heart attack if hormone replacement therapy is being done very vigilantly. But if you're going to a HRT clinic that is just running people through the mill and giving the typical 200 milligrams once or twice a week injection, and you're really not monitoring your numbers, over time that could lead into cardiovascular disease. And we want to make sure with every patient, we always make sure we run a lipid panel and make sure their cardiovascular function is safe before we even start that process. And then things like IGF-1 and insulin will influence our testosterone. With IGF-1, that's a marker that looks at growth hormone, okay? And growth hormone can influence testosterone, so that's why we will look at that. And then insulin, because you're going to realize, as you probably already know, blood sugar has a huge impact on testosterone, okay? And I will go over that. So I know that was a lot, and I know probably your head's already spinning. I'm going to make it a lot more simple, but I wanted to make sure I at least address these for our viewers because these are common questions that come up, and I at least wanted to hit upon it. The main importance of this slide here is it's not just testosterone. Oh, I got my testosterone, I'm good, everything's great, right? We know the body's multifaceted, and so is testosterone, so is hormone replacement. These things need to be assessed and looked at if doing hormone replacement or just messing with testosterone in general is something that you want to be done. So real quick, what is testosterone, right? Okay, this is a sex hormone produced by the testes in men. Basically, it's a hormone sent through the blood transmitting chemical message to different tissues, right? So basically, this is stimulating protein synthesis. That's why it's related with muscle growth, right? A lot of the times you're going to see that some of the symptoms connected capacity or mental function has a really big impact with testosterone. Weight stability has a big impact. Bone health has a big impact with testosterone, but it's basically a chemical messenger to activate and synthesize proteins to go and do their job, essentially. Obviously, some of the purpose of the testes, development of the penis and testes, deepening of the voice during puberty, appearance of facial hair, pubic hair starting at puberty and later in life. It may play a role in balding, right? That's where it comes to the DHT we just talked about briefly, right? Again, if we're converting a lot over to DHT and we're not kind of using that testosterone, we can have that male pattern baldness. We're not going to talk about it a ton, but in certain clinics, they'll give you a 5-alpha reductase inhibitor like finasteride or dutasteride. These are ways to block that testosterone from going over to DHT. There can be some complexities with it. There's something called post-finasteride polysaccharide syndrome that can create some issues with taking this medication. So if that's something that that you're going to a clinic and being done, you want to be aware of. Things always, nothing's perfect. Things will have some side effects to it, and you just want to be aware of that. Muscle size, strength, bone growth, which I've already talked about, libido, sperm production, cognitive function. These are all impacts of healthy testosterone. Okay, so we can see that it does quite a bit. That's why we are focusing so much on this. So, hormone replacement in longevity. I really wanted to talk about this because the last benefit you saw there, the function, right? There is a little bit of debate on it, but the literature is pretty congruent in regards to if you have low levels of testosterone, circulating testosterone levels, the likelihood of developing dementia-like symptoms later in life with lab low or hypogonadal function will impact cognitive function. So we can even see here, again, hormone replacement therapy and longevity. It was found that testosterone replacement of men suffering from late onset hypogonadism basically just means your testosterone's so low that your testes are not even functioning, right? Increased survival rate from 9 to 10% in 5 years, similar to basically who are not having any issues. So with normal androgynous testosterone secretion, so basically again, men who had low testosterone when they were treated for that low testosterone, they had increased survival rate, right? From 9 to 10% in that 5-year period compared to their normal testosterone counterpart. So again, just kind of showing the fact of longevity. And the reason why I mention this again is I always tell my patients, like, well, doc, is this safe? What should I do? And I always tell them, I said, when I hit 50, as long as if my testosterone is low, I will be taking it. There's no doubt about that, 100%. So maybe, if my testosterone drops even sooner than that, maybe it's not even 50, but absolutely that's something that I personally will be taking. I don't take right now currently, but at some point, definitely, just from the longevity standpoint and all the other improvements that we can have from a health standpoint. Here's another one, testosterone, and again, cognitive function. I flip-flopped the two. The first slide was longevity, obviously. This is cognitive repair. But so it says here, 18,599 patients, okay, that they basically retrospectively assessed. And you can see here the results from our meta-analysis, an increased risk of all-cause dementia with decreased total testosterone. Some studies found that an increased risk of Alzheimer's disease with a lower level of total T, free T, and bioavailable testosterone. So again, they're basically saying out of all of these people, we saw a strong correlation with low testosterone and having increased risk for Alzheimer's disease. Okay. So again, or all-cause dementia, right? So just kind of making that connection with how important that this testosterone is in hormone function in general for cognitive function and longevity. Okay, so do I have low T? Well, should I go see my doctor? Should I go see someone about this? What, when should I get off the couch, right? Or hopefully, not off the couch, but when should I go see my doc? So obviously the big ones, low energy, right? Low libido, erectile dysfunction, okay? Sleep disturbances, loss of muscle mass or inability to maintain muscle mass, right? Poor performance during workouts, or you're getting, you're doing your typical workout and your recovery is absolutely in the tank. You're like, just what's going on with my recovery? Hence poor recovery from workouts, weight gain or inability to lose weight. If we're having hair loss, noticing easier fractures, and then the big one again that men don't realize, depression and anxiety, and in certain cases even psychosis due to low T, right? So these are the big ones. And sometimes I would like to at least mention, sometimes patient comes in and like, hey, I don't I want to get my testosterone and my hormones checked. They come back and their testosterone, free testosterone, some of the other markers are in the lower quartile. But doc, I don't have any of these symptoms. I just wanted to have them checked. In that situation, it's not always, oh, well, it's still low, let's hammer you with testosterone, right? Or try to do this, support this naturally. A lot of the times, it can be the androgen, the affinity for androgen receptors. So if we don't have a lot of testosterone, but your androgen receptors are very sensitive and they're really good at binding that testosterone, you might not necessarily need testosterone, a total testosterone of 900 and a free testosterone of 20, right? So I do like to just mention that, just so you guys can hear that, the viewers can hear that, right? It's not always, oh, my testosterone's middle to low, lower third quartile, let's give you testosterone, right? We need to not only evaluate the numbers, but evaluate the patient coming in and the symptoms that we're dealing with, okay? So just important to understand that it's not always, right? It's the law of diminishing return, right? Just because my testosterone my total is through the roof and my free's through the roof, I'm gonna feel amazing, right? It's not necessarily testosterone levels are through the roof, right? The higher they are is not necessarily equal to the better you feel. Okay, so how to measure this. I've pretty much talked about how to measure, right? Clinicians, now this is according to the American Urology Association. So in standard medicine, it is a little bit ancient, okay? Where again, all they look at is total testosterone, level below 300 as a reasonable cutoff in supporting the diagnosis of low testosterone, okay? Again, kind of what I just mentioned, we could have a patient come in, their total T could be 500, their free T around 8 or 9, which is still relatively low, but technically normal. But if they start, those symptoms I just mentioned, my sleep is really off, my mood is unstable, I'm gaining a ton of weight, right? According to the gold standard here, you would not be treated with testosterone, or you basically could. I don't know what to tell you, right? In that situation, I would definitely look at supporting either naturally or talking about HRT replacement at that point. But always, for me, I always start natural first before we ever start talking about medications. So again, I kind of mentioned this, but free testosterone and more, right, is what we want to look at, right? Free testosterone is the key, one of the key markers to look at, okay? Not total testosterone. I always tell my patients, it sounds a little crude, but I don't really care about your total T all that much. I want to know where your free T is. I want to know where your DHT is. I want to know where your sex hormone binding globulin is. I want to know where your estrogens are at, right? So there's a lot going on to just in standard medicine. Where's your total T at? Okay, if you're not under 300, see you later. Okay. This is just a little flavor of what we run, right? This is a very small piece of what we run, but you can see here, again, going back in those numbers. In this patient, we look at their total T. Their total T was actually really good. This was after, by the way, this patient came in with low testosterone, came in with symptoms that we've already discussed, and this is after we've done some treatment where they are currently. So you can see total testosterone 953, that's great. The big thing here, again, what I want is the free testosterone. The number to kind of remember for everyone watching, 2%, you want your free testosterone to be roughly 2% of your total testosterone. And for this male, we hit that, 2.5%. That's great. That's fantastic. We looked at other markers, right? What's the bioavailability of the testosterone? So how much is that testosterone that we have in circulation usable, right? Because not all of it is always usable. So that was great. We looked at testosterone, fantastic. We looked at DHEA sulfate. So This is hands down is my favorite supplement. This is a supplement I can actually give. You can go over the counter and you can buy DHEA that will actually influence this number. And DHEA is like, I always tell my patients, it's the gasoline for the car. If testosterone was the car, DHEA is the gasoline. It's a precursor to your testosterone. Works fantastic with bringing up. Now, you're not going to get super physiological levels of free testosterone, but it will help bring a free testosterone up, 5, 4, which is life-changing, okay? And again, we look at that sex hormone binding globulin, okay? If I didn't mention this, what sex hormone binding globulin is it basically takes your testosterone and it binds it and it makes it inactive. Essentially, it just blocks it, right? I know it's a little bit graphic, but for me, it always sinks in my head. One of those old school revolvers, and we're loading bullets into the chamber. Sex hormone binding globulin is putting a blank into that chamber. Does nothing, right? We can't use that weapon, right? So that's kind of what sex hormone binding globulin does. Then in this patient, we looked at their estrogens. We looked at their dihydrotestosterone. That's the one that we do want some, but we don't want it, I don't want this 100 because we're definitely going to have we're going to have symptoms with potential prostate growth and balding with that, right? Because DHT is thought to stimulate some of the prostate. But typically around 50 is where we want that. And then we check your FSH, your LH. We check the prostate with this patient to make sure there was no issues with that. FSH, LH, I'll come into that, what that means in just a little bit. But again, this just shows you the extent of the blood work, and this is only just a small piece of the blood work that we ran for this patient. But you can see it's more than just, oh, I ran your total testosterone. Okay, erectile dysfunction, really important because this goes it goes under the radar all the time. Men never want to talk about it. I really have to probe it out of them. So what happens with erectile dysfunction? What's the physiology here? So male gets, this is for an erection, what happens? Male gets a stimulus, right? We release the endothelium, which is kind of like the tissue around the penis and in circulation, releases nitric oxide. This nitric oxide lowers something called cyclic GMP, and then this GMP causes calcium to go down, and it causes dilation of the blood vessel and increased blood vessel diameter. Bingo, that's your erection, right, in regards to the penis. When we're looking at ED, we always want to evaluate for vascular, right? Hence, with testosterone and cardiovascular dysfunction is common. We want to look at endocrine, right? That's where blood sugar, right? We talked about hemoglobin A1C. It's a marker of blood sugar. Research has shown, and I believe I have an article that when blood sugar drops, testosterone can improve just by focusing on blood sugar alone, okay? It could be neurological as well, could be trauma. Medications can cause this, like finasteride. That's that 5-alpha reductase inhibitor. That's the one that lowers that DHT, the balding and prostate growth hormone. Beta blockers can cause erectile dysfunction, so it's just kind of good to know that. Typically, in medicine, a phosphodiesterase inhibitor, so something that blocks the this is something that blocks the lowering of the cyclic GMP. So typically the common medication is Cialis, and some of the top urologists are doing daily Cialis 5 milligrams. I just put Evanafil because that's like these phosphodiesterase inhibitors can have some side effects. That Evanafil is shown to be like the one with the least side effects, but it's expensive. And then there's other aspects. You can do stem cells, you can do PRP, which is platelet-rich plasma. There's a lot of research coming with shockwave therapy to help erectile dysfunction, but you can do things, again, that help increase that oxygenation. These are all things that improve blood flow and improve vasodilation, and therefore can improve erectile dysfunction. Just a quick point to mention, because I think it is important as well. Another common, men do not want to talk about is Peyronie's disease, which is the curvature of the penis. And a lot of the times that can occur due to erectile dysfunction, right? The man does not receive a complete hard erection. They have intercourse, and that's trauma to the penis during that intercourse, right? Whether the men perceive it or not, there is micro trauma occurring. And if that occurs over time because of, mild ED, right? ED doesn't always have to be perform at all, right? There can be varying degrees. So over time, that trauma occurs, and it basically, think of it as almost like scar tissue builds up, and that scar tissue causes the penis to basically curve. But it's important to talk about, there are therapies. Reach out to a really good urologist. Typically, it's been FDA approved. They'll inject something called collagenase into that area of scar tissue. It kind of just breaks up the scar tissue, and that does be really effective. But that's something you would want to see a urologist about. So I just wanted to mention that briefly, because if I didn't, I feel like I'd be doing men a disservice, especially for those. They say roughly 7 to 9% of men will be dealing with this. And then for erectile dysfunction, it's pretty amazing. So they say, the research does state 40% at 40, 40%, at 50, 50%, at 60, 60% of men will be dealing with ED, erectile dysfunction. So it is a condition of aging, right? Atrophy and fibrosis of the tissue around the penis, right? So really important understanding that this is an aging issue. But I'll leave it at that. So this is great. And really, Cialis does way more than just helping for an erection. It's thought that it can help. It's actually FDA approved for reducing the size of the prostate as well. And there's also some research with it helping to improve that endothelial, the vascular function. So there's thoughts that it can have some cardiovascular benefits as well. So really, really cool, but you would obviously want a prescribing physician to manage that. And this is that article I just mentioned. So the role of glucose lowering medications in erectile dysfunction, okay? So again, talking about sugar, sugar. So basically, you're seeing here type 2 diabetic patients. Among these type 2 diabetic patients, advanced glycation end products and reactive oxygen species, basically think inflammatory, just inflammatory molecules, right? We know sugar is inflammatory, right? Derived from increased blood sugar state, are known to accelerate endothelial dysfunction, right, by lowering nitric oxide bioavailability, right? We talked about that in the last slide, right? Nitric oxide is how we basically get an erection from men. So again, you can just see, by having higher sugar, we create more inflammatory products, which decreases the production of nitric oxide, which results in a lower erection or lack thereof. Here's another one, erectile dysfunction predictors in cardiovascular events. So this is huge. If you get anything from this, just get this piece here. Basically, ED is the canary in the coal mine for cardiovascular risk. One research study said early onset signs of ED in a 3 to 5 year time frame precipitated a cardiovascular event, or cardiovascular disease at least. So basically what that means, 3 to 5 years from when that onset of ED occurred, they had diagnosable, or the likelihood of diagnosable cardiovascular disease increased exponentially. So really good study here. Again, they did a systematic review of a lot of data previously. They used really good data points here in regards to pulled data from PubMed, Embase, Cochrane Library, Medline. So these are really, really good sources they pulled info from. And they found that, again, a ton of patients, right? A ton of people that they prospectively looked at. Individuals were included in our meta-analysis. So they basically said they compared people with ED, men with ED, with those men without ED. The cardiovascular risk of ED patients was significantly increased by 43%. So basically, again, they compared men with ED and non-ED, and they saw the risk of cardiovascular disease increased by 43%. So again, canary in the coal mine, ED for cardiovascular function. Okay, so testosterone and cancer. A lot of the times this is a common question. Well, doc, I heard I'm going to get prostate cancer. I heard that's a possibility. This is very, very antiquated. That is no longer the thought process. So I want to just give you a little bit about this. All of this research, all of that hypothesis was based off of Dr. Huggins in 1941. Okay, so we're talking about all the way back from 1941 that's still being kind of brought up. In his very first published volume, what is now a highly respected journal called Cancer Research, I read how Dr. Huggins, co-investigator, used new. So basically, they looked at acid phosphatase, okay, which is now known as PSA, that marker for that assess your prostate, and to show that lowering testosterone by castration or estrogen. They didn't literally castrate them; they gave them a medication that shut down their testosterone function. Treatment caused prostate cancer to regress, okay, and how T injections or testosterone injections had caused an enhanced growth of prostate cancer in these men. Okay, so I'm just going over this is what he was saying. Okay, I'm not saying that this is true, but this is what Dr. Huggins was saying back in 1941. Huggins and Hodgins written, so this is where the flaw comes in. They took, in this study that has been lore since 1941 to now, they took 3 men in this study. 3 men, and they all injections, but results were given for only 2 men because one of the men dropped out, and then one of the men had already been chemically castrated. So all of this research that is still talked about present day was based off 1 man. And really what the current data shows now is there's no difference. So I believe it's roughly around 7 to 14% of men will develop prostate cancer in general. We don't change anything. That's just the percentage projection. With or without testosterone, it stays the same. It stays the same. Okay? And that's basically what this says here. Okay? This is the website here. I got this from Abraham, I'm not even going to pronounce that, but he's an MD out of Harvard. And this was a great article. Probably, it's long and lengthy, but if you really want to dive into all the intricacies of it, definitely when you're watching this recording, type this down, look into this. This was awesome. It was very in-depth, very detailed. But again, I want to just mention this. He said he did a study of 345 men and found that the degree of testosterone deficiency correlated with the degree of cancer risk in men was basically negligible, right? Men whose testosterone levels were in the bottom third of the group were so quite the contrary. Now they're starting to see that your likelihood of developing cancer increases with low testosterone, okay? Diagnosed on biopsy as men in the upper third, okay? So these findings add to the concern that low testosterone could be potentially a risk for prostate cancer. So pretty cool that is coming out. So hormone support. So obviously we can do testosterone, right? You want to make sure that's being managed very safely. Typically what should be done is probably, it depends on the case, but I do not recommend for any of my men to do, like in some of these HRT clinics, 1 injection every 2 weeks. with hormones in general is we want stability, right? So we don't want to see lots of fluctuations in hormones. So if that's the case, definitely want to question it and what's going on. A lot of urology and a lot of the top end typically doing like 50 milligrams twice a week. That seems to be the most efficacious, because typically the type of testosterone you're going to use is called cypionate for the injection, and that usually has a half-life of somewhere around 7 to 10 days. So around 7 to 10 days, the testosterone will start dropping. So if you technically do it twice a week, you pretty much ensure yourself that that hormone is going to be nice and stable and it's not going to drop, okay? I won't go into more detail. We could talk about anthenate and cypionate and propionate. I won't do that. In my research, one thing that I did find, which was pretty cool, was cypionate. You can hold on a little bit more to sodium. So if you do have blood pressure issues and you are doing testosterone, you want to be careful with cypionate. Anthenate seems to not have as much blood pressure related issues when taking it, but it has a shorter half-life, and I won't get into that. This talk's not about injectables and things like that. It's talking about, again, my first approach is treating this naturally. Before we get on medications, how can I take care of this naturally, okay? And then you can do, there are oral, the newer oral testosterone medications are seeming to be a little bit safer, because back in the day, a lot of liver issues with oral testosterone. Everyone wanted to stay away from it. It's now getting better. I won't go into the detail whether I suggest it or not that, but I just at least want to mention it. We talked about injectables, and you can even do topical. There's a lot of controversy around topical. Topical works really good, and a lot of guys, they don't want to have to inject themselves, right? Some could care less, but some don't want to inject themselves. So topical works really good. Our biggest concern with that we always talk to our patients about is transmission of it, right? So that gets into a little bit more detail, which is for another discussion, but you just want to be aware of the transmission of that. And then nasal. I do want to mention this. One of the side effects, again, with testosterone, which will go into potential side effects, is hematopoiesis or erythropoiesis. So increased red blood cells. So your body tends to make more red blood cells. And really what you do for that is you can do medical phlebotomy, or it's not considered, like, basically if you go to a blood draw donation center and you're like, oh, I have high red blood cells, a lot of times they'll say, no, you can't donate blood. But I would say, if it were me and I had erythrocytosis or hematopoiesis, high red blood cells, I'd go donate blood, right? That's basically how you would correct that. But that being said, there's a nasal spray. Now you have to use it very frequently, but the nasal spray helps prevent that, okay? And then also lowering the dose would obviously affect that, but I just wanted to mention that. I thought that was really cool. Nasal spray could help prevent that, which is kind of a geek out thing that I kind of got excited about. Other things we can do, again, that's not for this conversation, but there's, in regards to testosterone and hormone production, there's thought about growth hormone, HCG, human chorionic gonadotropin, your modulator, and this is selective androgen receptor modulator. Those are other kind of more in the weeds topics. Clomid, peptides, aromatase inhibitors. I didn't put it on here, but those the 5-alpha reductase inhibitors as well. Those are all other avenues, but that's getting down deep into the weeds. Some things that we can do naturally. DHEA, again, I already mentioned this. These are all obviously over the counters. I love DHEA. It should still be used cautiously. You should be still having your levels being assessed and monitored, but it works fantastic and there's very few side effects. Usually I will give small amounts to women. I always tell them, watch for acne. That's typically the big sign. Even for men, acne will start kind of creeping up, but a man or a woman says, hey, my energy's through the roof, I feel great, I'm amazing, I can deal with a little bit of acne. Zinc, Tunga Ali, Tribulus, Fidogia agresta, pregnenolone, vitamin D, saw palmetto, fenugreek, ginger, ashwagandha, these all have been shown to have some effect with helping testosterone production. I won't go into the detail of what each one does because I'm already probably boring you, but this is really cool. These are really good natural herbs that have very, very minimal side effects that can help support testosterone. They're not all going to help increase testosterone. For example, like your saw palmetto, okay, that helps with with liver function, some aromatase. It is thought to naturally decrease some of that aromatase, that conversion of testosterone into sex hormone binding globulin, or converting it over to estrogen. But saw palmetto is, again, it's thought to basically not cause that testosterone to go down into other pathways. Okay, really, really awesome. There's a great study which I have just on the next slide. But HIIT training, high intensity workout training, has been shown to increase testosterone. So exercise, really, really important. Okay, and again, I know we just went right into testosterone and some of these other therapies, but lifestyle factors are first and foremost. If we're not doing that, we can do all of this. It's a waste. It is a waste. Okay. So I really, really want to talk, mentioned in regards to the high intensity training, proper nutrition, which we're going to talk about in just a second here, continued ways to improve testosterone function, right? Proper sleep. Sleep is crucial, right? When we're stimulating the majority amount of our growth hormone, right? Growth hormone can stimulate testosterone production, is sleep. So getting into deep sleep will stimulate growth hormone, will also then therefore stimulate testosterone production. So sleep's really important. If we're noticing any snoring or any signs of morning drowsiness, morning headaches, go get a sleep study done. That's one of the biggest contributing factors that men and women don't realize. Managing stress, right? I know that's a loaded one, but really trying to be mindful of stress. A lot of times people will use exercise as their way to relieve stress, really important. I recommend trying to stay away from alcohol as much as possible. It is a drug, right? I take that approach, right? And it's a toxic drug at that. And then trying to avoid xenoestrogens. These are compounds that we get exposed to that will basically act like estrogens on the body, right? Men need estrogen, but if we're having high levels of estrogen, we're going to see more female-like tendencies, right? This is where weight gain starts to happen. This is where gynecomastia starts happening. This is where we start getting hair loss as well. So these are common xenoestrogens, okay? If they can't see it from the video, I'll just quickly run through this. So make sure you have really good, healthy, and clean water, right? Pesticides, herbicides, cleaning products, plastics, canned foods, dental sealants, receipts. My wife always gives me a hard time for this because she always makes fun of me. I will never touch the receipts. Whenever they hand me the receipt, I either tell them they can throw it out or I open up the plastic. Granted, I'm holding the plastic bag, but I'll have them put them in the plastic bag. I never touch receipts. I hate touching them. Air and dust, air fresheners, laundry products, home furnishings, right? Everyone has probably had that experience where you're so excited to get that new furniture, you pull the plastic off and you're like, oh, I need to leave that outside for a bit. Hair dyes, nail polish remover, cosmetics, personal care products, shampoo, deodorant, moisturizer, perfume, sunscreen, medical devices, birth control pills, toys, building materials, photocopiers and printers, and artificial food dyes, right? So just being aware of some of this and trying to do alternatives is a huge start. I use, for an app, it's called EWG, Environmental Wellness Group. You can kind of search a lot of these products that you may have in the home and see kind of what the quality is on them. So that's a great piece to start, okay? So here's that interval training that I talked about, okay? The effects of high intensity interval training periods on morning serum testosterone and cortisol levels in physical fitness and age men from 35 to 40. So again, I wanted to place a priority on this. Basically think testosterone and cortisol, they can be considered to be inversely related. But basically, again, this is what they found. 3 sessions per week each of them lasting 1 hour. Conclusion, high intensity interval training continued over an 8-week period. So this regimen over an 8-week period modulates the balance between testosterone and cortisol levels, improves physical capacity in men of 35 to 40 years old. Okay, so again, the fact that we can modulate our hormones just through exercise is pretty awesome. Possible side effects. So we talked about hair loss, okay, right, with increasing that DHT. So we want to just be aware of testosterone can, again, convert into basically two main offshoots, right? It can go into our estrogens, mainly that estradiol. It can go into, okay, excuse me, 3, I said 2, and then it can go into DHT. Those are the areas that we really want to be aware if we're shuttling a lot of our testosterone into those. So we just want to be aware of that. Acne, right? Cardiovascular side effects, right? We already talked about. I know we mentioned that ED is kind of like a precursor to cardiovascular function, but if, again, we're just haphazardly doing testosterone replacement, that can have some serious cardiovascular side effects. So we typically don't want testosterone to be super physiological, meaning extremely high. Infertility, so slash hypogonadism, they're very similar. So this is one that I really wanted to mention as well. If you take your testosterone, you are basically going to shut down your internal production of spermatogenesis. So any male that is interested in doing TRT, if you're taking testosterone for long periods of time, right, years and years and years, you will basically shut down your ability to become fertile, okay? And I always mention that. Now, you can use things like Clomid or HCG. Those are medications to increase. And obviously, you can do natural things, but in conventional medicine, that's typically what's used to maintain fertility, but also help bring back up testosterone levels. But that's something that's really important that we want to be aware of. Now, it is thought if you're on testosterone, someone like the bodybuilders will go like 8 weeks on, 8 weeks off, 8 weeks on, 8 weeks off. That does maintain fertility. And again, it's thought that if you've done it for a short time, you can get fertility back in that some say even as soon as 3 months, but anywhere from 3 to 7 month period. So take testosterone, all of a sudden I'm infertile for the rest of my life, right? But if it's someone who's on testosterone for 2 years, 3 years, probably the likelihood of being able to be fertile again is going to be low. It's going to be hard, okay? But that's something I just wanted to talk about, right? We could have potential BPH, so enlargement of that prostate that we talked about, but that's if we convert a lot into that DHT. Mood instability, right? Everyone probably has heard like roid rage or things like that, but that's again, this is when we're not dosing correctly or the hormones are just doing lots of ups and downs, right? Gynecomastia, again, if we're converting over or aromatizing into a lot of estrogen, right? They have aromatase inhibitors called like anastrozole. Again, a lot of the times in typical clinics, they'll just give you testosterone and they'll give you anastrozole with it to prevent converting into that estrogen. That's not the right way to go. A lot of the times you can support testosterone without giving a aromatase inhibitor. But if you're that particular case and you're aromatizing a lot into estrogen, you can get gynecomastia. And then I already talked about that polycythemia or that hematopoiesis, a lot of the red blood cells, right? I'm not going to get into the details here in regards to the signaling and the firing from the brain. We talked about that briefly, but these are just possible side effects that I want you to be aware of. And then these are some of my articles that I pulled from, my citations. But really the big thing is that we want to start with good nutrition, okay? Typically, they were talking about like a Mediterranean diet, but a low, like a paleo type diet, low carbohydrate diet or a lower carb diet, right, to help control blood sugar. That's the first thing to start. Making sure we're getting proper sleep. If we have any potential signs of sleep apnea, go get a sleep study done. They're relatively cheap. You can do them at home, and that's a huge piece, right? But with that, weight loss helps sleep apnea. So exercise, right? Good high intensity interval training, 3 times a week for an hour length for 8 weeks showed to modulate testosterone positively. Then you can get into taking some of the herbals, but before you even do that, proper blood work. Make sure you're having proper blood work done. That probably goes first and foremost. And then after that's done, then you can talk about some natural herbs that you could try and do, right? I love DHEA, I love pregnenolone if the blood work is telling me that we need it. We're not going to just do it haphazardly. And then lastly, if we need it, medications if that comes to the case, right? That's the testosterone and other things like that. So that's my approach, and a lot of I can confidently say should a lot of HRT or hormone replacement clinics cutting edge approach as well. Again, I appreciate you guys being here. Just slightly over that hour time frame. That's kind of where I wanted to land at. But thank you again, and if there's any questions, please feel free to ask them.
You said Mediterranean diet.
Yeah.
Something to try.
Yeah, like a Mediterranean. Basically, the gist of it is, right, like high protein, moderate to high fat, right, low carbohydrate, right? And then usually a lot of the times, the big difference between that and a paleo is Mediterranean does kind of focus more on marine animals, right? Fish, things like that. Lots of high olive oil. In that diet, they will incorporate a lot of like beans and legumes, that's where paleo will differ a little bit, where paleo, you're not going to do a lot of legumes on that diet. That's really the biggest difference. But basically think lots of good animal meat, good clean animal meat, right? Grass-fed red meat, wild-caught fish, antibiotic-free, cage-free poultry, right? With lots of good vegetables, and then trying to keep like your pastas, your breads, your cereals, your bagels, your muffins, try to keep those limited, right? So that's really, I mean, we tend to overcomplicate nutrition when we're trying to get, from good to great. Yes, we need to make fine tune things, but to just get really good health, nutrition is relatively simple, right? Low carbohydrate, low amount of carbs, so we control our blood sugar, good quality protein with good healthy fats, right? Less fat from dairy, more fat from our good healthy oils, olive oil being the main one, avocado oil, coconut oil, we can debate on that. I do think it is healthy, but we have to be aware it is a saturated fat, so that can influence, lipid levels. But that's really nutrition in a nutshell. And then obviously in moderation. I always tell all my patients, I want vegetables to be first and foremost. A lot of people will say, especially men, oh, I'm going to load up on the protein, right? I want vegetables first, okay? Vegetables as the main dish, and then your protein as the side dish, right? So that's kind of my approach on nutrition. And if you guys want to take off, please don't feel like, I know it's Saturday, but if any questions come up, please let me know.
I think I'm going to try the diet thing, and then I might set up an
Yeah, absolutely.
some blood work.
Absolutely. Yep. But the keys I really enjoyed teaching was the prostate cancer. I do like to talk about in regards to infertility with that. That's something that we'll have a detailed discussion if testosterone is decided to be used. and then the ED piece. Those I felt were really, I was happy to be able, and I enjoyed being able to talk about those. So those are kind of like the highlights, I feel.